Introduction to Abdomen. The abdomen is the lower part of the trunk and lies below the diaphragm. It is divided by the plane of the pelvic inlet into a larger upper part, the abdomen proper, and a smaller lower part, the true or lesser pelvis and perineum. The abdomen is bounded to a large extent by muscles, which can easily adjust themselves to periodic changes in the capacity of the abdominal cavity. They can thin out to accommodate distensions of the abdomen imposed by gas, fat foods and fluid. The abdomen contains the greater parts of the digestive and urogenital systems. In addition, it also contains the spleen, the suprarenal glands, and numerous lymph nodes, vessels, and nerves. The abdominal wall is made up of the following 6 layers. 1. Skin. 2. Superficial fascia. 4. Muscles. 1. A continuous layer of fascia, named region-wise as the diaphragmatic fascia/ossea transversalis, fascia iliaca, anterior layer of thoracolumbar fascia, and pelvic fascia. Extraperineal connective tissues. 2. 3. The perineum, which provides a slippery surface for the movements of the abdominal viscera against one another. The abdominal cavity is much more extensive than what it appears to be when seen from the outside. It projects upwards deep to the costal margin to reach the diaphragm. It also projects downwards as the pelvic cavity within the bony pelvis. Thus a considerable part of the abdominal cavity is overlapped by the thoracic bony cage above, and by the bony pelvis below. The importunca of the abdomen is manifold. To a physician, no examination is ever complete until he/she has thoroughly examined and auscultated the abdomen by the stethoscope, Greek look at breast, of the patient. In fact, the patient, irrespective of his complaints, is never satisfied without an examination of his/her abdomen. To an obstetrician and gynecologist, the importance of the abdomen is obvious. The surgeon considers the abdomen as an enigma because in a good proportion of his/her cases, the cause of abdominal pain, or the nature of an abdominal lump, may not be decided in spite of all possible investigations. Laparotomy, i.e. opening up of the abdomen by a surgeon, may reveal the disease in many obscure cases, but not in all of them. In the course of evolution, adoption of the erect posture by man has necessitated a number of structural modifications in the abdominal wall and pelvis, some of which will be mentioned in the appropriate sections. Osteology. The various bones present in relation to the abdomen are the lumbar vertebrae, the sacrum, and the bony pelvis. These are described below. The lower ribs and costal cartilages are also closely related to the abdominal wall. These have already been considered along with the thorax, section 2, in volume 1. Lumbar vertebrae. There are 5 lumbar, Latin loin, vertebrae, of which the first 4 are typical, and the 5th is atypical. A lumbar vertebra is identified by a. its large size, and a. the absence of costal facets on the body, c. absence of foramen in transverse process. Typical lumbar vertebra. 1. The body is large, and is wider from side to side than from before backwards. The height of the body is slightly greater anteriorly than posteriorly. This difference contributes to the forward convexity of the lumbar spine, Figs 15.1a and b. 2. The vertebral foramen is triangular in shape, and is larger than in the thoracic region, but is smaller than in the cervical region. The pedicles are short and strong. They protect backwards from the upper part of the body, so that the inferior vertebral notches are much deeper than the superior. 4. The laminae are short, thick, and broad. They are directed backwards and medially to complete the vertebral foramen posteriorly. The overlapping between the laminae of the adjoining vertebrae is minimal. 5. The spine forms a vertical quadrilateral plate directed almost backward and only slight downwards. It is thickened along its posterior and inferior borders. 6. The transverse processes are thin and tapering, and are directed laterally and slightly backwards. These develop from the costal element and are homologous with the ribs in the thoracic region. The postero-inferior aspect of the root of each transverse process is marked by a small, rough elevation, the accessory process, which represents the true transverse process of the vertebra as these develop from the transverse element of vertebra. The length of the transverse processes increases from vertebra L1 to L3 and, thereafter, it decreases, Fig 15.1b. 7. The superior articular processes lie farther apart than the inferior. Each process bears a concave facet facing medially and backwards. The posterior border is marked by a rough elevation, the mammillary process. 8. The inferior articular processes be nearer to each other than the superior. Each process bears a convex facet facing laterally and forwards. 5th. Lumbar vertebra, the most important distinguishing features are, the efferents rares processes are thick, short, and pyramidal in shape. Their base is attached to the whole thickness of the pedicle and encroaches on the side of the body, Fig 15.2a. The distance between the inferior articular processes is equal to or more than the distance between the superior articular processes. C. The spine is small, short, and rounded at the tip. One other features of the 5th lumbar vertebra are as follows. The body is the largest of all lumbar vertebrae. Its anterior surface is much extensive than the posterior surface. This difference is responsible for the creation of the sharp lumbosacral angle and is 120 degrees in an adult. The pedicles are directed backwards and laterally. The superior articular facets look more backwards than medially, and the inferior articular facets look more forwards than laterally, as compared to other lumbar vertebrae, Fig 15.2b. Attachments and some relations of lumbar vertebrae. 1. The upper and lower surface lie contact with the intervertebral discs. 1. The upper and lower borders give attachment to the anterior and posterior longitudinal ligaments in front and behind, respectively. 2. Lateral to the anterior longitudinal ligament, the right cruce of the diaphragm is attached to the upper 3 vertebrae, and the IE cruce of the diaphragm to the upper 2 vertebrae. 3. Behind the line of the crura, the upper and lower borders of all the lumbar vertebrae give origin to the psoas major, Fig 15.3. 4. Across the constricted part of the body on either side tendinous arches are offached. The lumbar vessels, and the gray ramus comune icons from the sympathetic chain, pass deep to each of these arches. 5. Vertebral Canal. 6. The part of vertebral canal formed by the first lumbar vertebra contains the cones medullaris. The part formed by lower 4 vertebrae contains the cauda equina. The canal of all the lumbar vertebrae contains the spinal meninges. 7. Vertebral arch. 8. The pedicles are related above and below to spinal nerves. 9. The nominee provide attachment to the ligamentum flava. The spine provides attachment to the posterior layer of the lumbar fascia, Fig 15.3. The interspinous and supraspinous ligaments. The interspinous muscles. Transverse processes. 1. The tips of the transverse processes of all lumbar vertebrae give attachment to the middle geniure of the lumbar fascia. In addition, the tip of the first process gives attachment to the medial and lateral arcuate ligaments, see Fig 26.1, and the tip of the fifth process to the iliolumbar ligament, see Fig 34.7. 2. The faint vertical ridge on the anterior surface of each transverse process gives attachment to the anterior layer of the lumbar fascia. Medial to the ridge, the anterior surface gives origin to the psoas major, and lateral to the ridge to the quadratus lumborum, Fig 15.3. 3. The posterior surface is covered by deep muscles of the back, and gives origin to the fibers of the longissimus thoracis. The accessory process gives attachment to the medial intertransverse muscle. 4. The upper and lower borders provide attachment to the lateral intertransverse muscles. The articular facets. 1. The concave articular facets permit some rotation as well as flexion and extension. 2. The mammillary processes gives attachment to the multifidus and to the medial intertrans muscles. Ossificatone. A lumbar vertebra ossifys from 3 primary centers, 1 for the body or centrum and 1 each for each half of the neural arch. These appear in the 3rd month of fetal life. The 2 halves of the neural arch fuse with each other, posteriorly during the first year. Fusion of the neural arch with the centrum occurs during the 6th year. The posterolateral parts of the body develop from the center for the neural arch. There are 7 secondary centers as follows: an upper annular epiphysis for the upper surface of the body, a similar epiphysis for the lower surface of the body. Fig 15.5, Spondylolisthesis of fifth lumbar vertebra. Fig 15.6, Cauda equina syndrome. Fig 15.7, Posterolateral disc prolapse 2 and 4. 1 center for the tip of each transverse process. 5 and 6. 1 center for each mammillary process. 1 center for the tip of the spine. The lumbar region is a common site of a number of developmental deformities, causing symptoms ranging from simple backache to serious paralytic manifestations. Sabatialization of the lumbar vertebra. The lumbar vertebra or its transverse process may be fused, on one or both sides, with the sacrum. Sometimes the transverse process may articulate with the ala of the sacrum or with the ilium. This may press on the fifth lumbar nerve. Sometimes the body ossifies from 2 primary centers, and if one center fails to develop, it results in a hemivertebra. Spina bifida, the 2 halves of the neural arch may fail to fuse, leaving a gap in the midline. This is called spina bifida. Meninges and spinal cord may herniate out through the gap. Protrusion of meninges alone results in the formation of a cystic swelling filled with cerebrospinal fluid. This swelling is called meningocele, Fig 15.4a. When the spinal cord is also present in the swelling, the condition is called meningomyelocele, Fig 15.4b. The central canal of the hemiated part of the cord may be dilated. This condition is called syringomyelocele. At times the spinal cord may itself be opened posteriorly. The condition is then called myelocele. Sometimes a spina bifida is present, but there is no protrusion through it, so that there is no swelling on the surface. This is referred to as spina bifida occulta. Spondylolisthesis. Sometimes the greater part of the fifth lumbar vertebra slips forwards over the sacrum. Normally the tendency to forward slipping is prevented by the fact that the inferior articular processes of the fifth lumbar vertebra lie behind the superior articular processes of the first sacral vertebra. At times, however, the inferior articular processes, spine and laminae of the fifth lumbar vertebra are separate from the rest of the vertebra, due to an anomaly in the mode of ossification. The body of the vertebra can now slip forwards, leaving the separated parts behind. Fig 15.5. Spondylolisthesis may be the cause of backache and of pain radiating along the course of the sciatic nerve known as sciatica. Fracture dislocation. Fracture dislocation of lumbar vertebrae results in the CAUDAEG syndrome, Fig 15.6. It is characterized by aflaccid paraplegia, saddle-shaped area of anesthesia, and analgesia. Sphincter disturbances in the form of incontinence of urine and feces. See impotence. In the young adults, the discs are very strong and cannot be damaged alone. However, after the second decade, degenerative changes set in, resulting in necrosis, with sequestration of nucleus pulposus, and softening and weakness of the annulus fibrosus. Such a disc is liable to internal or eccentric displacement or external derangements, resulting in prolapse due to rupture of annulus fibrosus even after minor strains. Cauda equine syndrome described above. The unequal tension in the joint in internal derangement leads to muscle spasm and violent pain of acute lumbago. Disc prolapse is usually posterolateral, Fig 15.7. This presses upon the adjacent nerve roots and gives rise to referred pain, such as sciatica. Disc prolapse occurs most commonly in lower lumbar region and is also common in lower cervical region, C5-C7. In sciatica, the pain is increased with rise of pressure in canal, as in sneezing, straight leg raising tests is positive, and the motor effects, with loss of power and reflexes, may follow. The spine of thoracic vertebrae may point to one side. The condition is scoliosis, Fig 15.8. There may be projection of the spines posteriorly due to osteoporosis of the bodies of vertebrae leading to kyphosis, Fig 15.9. Anterior convexity of lumbar vertebrae may get exaggerated, leading to major lordosis, Fig 15.10. The sacrum/vertebra magnum. The sacrum, Latin sacred, is a large, flattened, triangular bone formed by the fusion of 5 sacral vertebrae. It forms the posterior-superior part of the bony pelvis, articulating on either side with the corresponding hip bone at the sacroiliac joint. The upper part of the sacrum is massive because it supports the body weight and transmits it to the hip bones. The lower part is free from weight, and therefore tapers rapidly, Fig 15.11. Being triangular, the sacrum has a base or upper surface, an apex or lower end, and 4 surfaces: pelvic, dorsal, and right and left lateral. The pelvic surface is smooth and concave. The dorsal surface is irregular and convex. The lateral surface is irregular and partly articular. The sacrum is divided by rows of foramina into a median portion, transverse bisacral canal. A pair of lateral masses formed by fusion of the transverse processes posteriorly, and of the costal elements anteriorly. When placed in the anatomical position A, the pelvic faces downwards and forwards. The upper surface of the body of the first sacral vertebra slopes forwards at an angle of about 30 degrees. The upper end of the sacral canal is directed almost directly upwards and slightly backwards. Features. Base. The base is directed upwards and forwards. It is formed by the upper surface of the first sacral vertebra, and presents features of a typical vertebra in a modified form. 1. The body is lumbar in type. It articulates with vertebra L5 at the lumbosacral joint. The projecting anterior margin is called the sacral promontory. The surface slopes forwards at an angle of 30 degrees. 2. The vertebral foramen lies behind the body, and leads into the sacral canal. It is triangular in shape. 3. The pedicles are short and are directed backwards and laterally. 4. The laminae are oblique. 5. The spine forms the first spinous tubercle. 6. The superior articular processes project upwards. The facets on them are directed backwards and medially. 7. The transverse processes are highly modified. Each process is massive and fused with the corresponding costal element to form the upper part of the lateral mass of the sacrum, Fig 15.11. The base of the lateral mass forms a broad sloping surface spreading fan-wise from the side of the body. It is called the M of the sacrum. The ala is subdivided into a smooth medial part and a rough lateral part. Apex. The apex of the sacrum is formed by the anterior surface of the body of the fifth sacral vertebra. It bears an oval facet for articulation with the coccyx. Pelvic sacrum. This is concave and directed downwards and forwards. The median area is marked by 4 transverse ridges, which indicate the lines of fusion of the bodies of the 5 sacral vertebrae. These ridges end on either side at the 4 pelvic sacral foramina, which communicate with the sacral canal through the intervertebral foramina. The bony bars between the foramina represent the costed elements. Lateral to the foramina, the costal elements unite with each other and with the transverse processes to form the lateral mass of the sacrum, Fig 15.11. Dorsal surface. The dorsal surface of the sacrum is rough, irregular, and convex, and is directed backwards and upwards. 1. In the median plane, it is marked by the median sacral crest which bears 3 to 4 spinous tubercles, representing the fused spines of the upper 4 sacral vertebrae. Below the 4th tubercle, there is an inverted U-shaped gap in the posterior wall of the sacral canal. This is called the Sucrose Hiatus. It results from failure of the laminae of the 5th sacral vertebra to meet posteriorly, Fig 15.12. 2. Lateral to the median crest, the posterior surface is formed by the fused laminae. 3. Lateral to the laminae and in line with the superior articular process of the first sacral vertebra, there are 4 articular tubercles, representing the fused articular processes of adjacent vertebrae. The inferior articular processes of the 5th sacral vertebra are free and form the sacral cornua, Latin horn-like, which project downwards at the sides of the sacral hiatus. 4. Lateral to the articular tubercles there are 4 dorsal sacral foramina. They communicate with the sacral canal through the intervertebral foramina. 5. Lateral to the foramina, there is the lateral sacral crest on which there are transverse tubercles, representing the fused transverse processes. Lateral surface. It is formed by the fused transverse processes and the costal elements of the sacral vertebrae. It is wide above and narrow below. The upper wider part bears an L-shaped auricular surface anteriorly, and a rough, deeply pitted area posteriorly. The auricular surface is formed by the costal elements. It articulates with the auricular surface of the hip bone at the sacroiliac joint. The posterior, roughened and pitted area is formed by the transverse processes. The abrupt medial bend at the lower end of the lateral surface is called the inferior lateral angle of the sacrum. Fused laminae. The sacral canal. It is formed by the sacral vertebral foramina, and is triangular on cross-section. The upper end of the canal appears oblique, but actually it is directed upwards in the anatomical position. Inferiorly, the canal opens at the sacral hiatus, and laterally it communicates through the intervertebral foramina with the pelvic and dorsal sacral foramina. The sacral canal contains the spinal meninges. The phylum terminate and the subdural and subarachnoid spaces end at the level of the second sacral vertebra. Therefore, the lower sacral nerves and phylum terminal pierce the dura and arachnoid at this, S2, level. Attachments on the sacrum. 1. The anterior and posterior edges of the body of the first sacral vertebra give attachment to the lowest fibers of the anterior and posterior longitudinal ligaments. The lamina of this vertebra provide attachment to the iowisp pair of ligamentum flava. 2. The rough part of the ala gives origin to the iliacus anteriorly, and attachment to the lumbosacral ligament posteriorly. The upper part of the renfri sacroiliac ligament is attached to its margin, Fig 15.11. 3. The part of the pelvic surface lateral to the bodies of the middle three pieces of the sacrum gives origin to the piriformis, Fig 15.11. The area extends into the intervals between the pelvic sacral foramina and is E-shaped. 4. The dorsal surface gives origin to the erector spinae along a U-shaped line passing over the spinous and transverse tubercles. The area in the concavity of the U gives origin to the piriformis, Fig 15.12. 5. The interosseous sacroiliac ligament is attached to the rough pitted area of the lateral surface, behind the auricular surface, Fig 15.12. 6. The lower narrow part of the lateral surface, below the auricular surface gives origin to the gluteus maximus, attachment to the sacrophereros and sacrospinous ligaments, and origin to the coccygeus, in that order from behind forwards, see Fig 34.7b. Point 7. The inferior lateral angle gives attachment to the lateral sacrococcygeal ligament. Relations of the sacrum. 1. The smooth part of the ala is related, from medial to lateral side, to the sympathetic chain, the lumbosacral trunk, the iliolumbar artery, and the obturator nerve. All these structures are overlapped by the psoas major muscle, Fig 15.11. 2. The pelvic surface is related to the median sacral vessels in the median plane. The sympathetic trunks along the medial margin of the pelvic foramina. The peritoneum in front of the bodies of the upper 2/2 pieces, interrupted obliquely by the attachment of medial limb of the pelvic or sigmoid mesocolon, see Fig 18.14. The rectum in front of the bodies of the lower 2½ pieces. The bifurcation of the superior rectal artery lies between the rectum and the third sacral vertebra. Structures transmitted through foramina. 1. The pelvic sacral foramina transmit, a ventral rami of upper 4 sacral nerves. B. The lateral sacral arteries. 2. The dorsal sacral foramina transmit the dorsal rami of upper 4 sacral nerves. 1. The following structures emerge at the sacral hiatus. The fifth sacral nerves which groove the lateral parts of the fifth sacral vertebra. A pair of coccygeal nerves. Phylum terminal which passes to the coccyx. Sex differences. The sacrum shows a number of important sex differences. These are as follows. L. The relationship of the length and breadth of the sacrum can be expressed quantitatively by using the sacral index, which is calculated as Breadth across the base x 100. Length from promontory to apex. The male sacrum is longer and narrower than in the female. The average sacral index is about 105 in the male and about 115 in the female. 2. The width of the body of first sacral vertebra is greater than that of each ala in the male. In female, the two are equal. 3. The dorsal concavity of auricular surface is less marked in male. In both, the auricular surface extends onto upper 3 sacral vertebrae. 4. The concavity on the ventral aspect of sacrum is more uniform, and is shallower in males. In females, the concavity is irregular, especially between S1 and S2 and between S3 and S4. 5. The sacrovertebral angle is more prominent in the female and the downward direction of the pelvic surface is greater than in the male. The size of pelvic cavity is more in females. The ossification of the sacrum should be regarded as the ossification of 5 separate vertebrae. However, the upper 3 vertebrae have additional primary centers for the costal bars. Thus there are 21 primary centers. 6 for the bodies, 10 for the arches, and 6 for the costal bars. 14 secondary centers, 10 for the epiphyses of the bodies, 2 for the auricular surfaces. 3 and 2 for the margins below the auricular surfaces. The primary centers appear between 2nd and 8th week of fetal life, and fuse with each other between 2nd and 8th years of life. The secondary centers appear at puberty and fuse by 25 years. Coccyx. The coccyx, Greek cuckoo's beak, is a small triangular bone formed by fusion of 4 rudimentary coccygeal vertebrae, which progressively diminish in size from above downwards. The bone is directed downwards and forwards, making a continuous curve with the sacrum. Features. The first coccygeal piece is the largest. It is commonly found as a separate vertebra. The upper surface of its body forms the base of the coccyx, which articulates with the apex of the sacrum. Projecting upwards from the posterolateral side of the base are the Coccygeal Cornua, which represent the pedicles and superior articular processes. They articulate with the sacral cornua and are connected to them by triterocornua. 1 leg feet. Memph's rudimentary transverse processes project laterally and slightly upwards from the side of the base. They may articulate or fuse with the inferior lateral angle of the sacrum, creating a 5th pair of sacral foramina. The 2nd, 3rd, and 4th coccygeal vertebrae are mere bony nodules which diminish successively in size and are usually fused together. Attachments. The dorsal surface of the coccyx give, 1 origin to the gluteus maximus on either sides. 3 origin to the sphincter on the extremus at the tip. 1 attachment to the dorsal sacrococcygeal ligaments and the terminal at the first piece. The pelvic surface, 1 provides insertion to the coccygus and to the levator end on either side. 2 provides attachment to the ventral sacrococcygeal ligament over the first 2 pieces. 3 it is related to the ganglion impar and the glomus coccygeum. The lateral margins provide attachment to sacroiphalbarobs and sacrospinous ligaments, see Figs 29.3 and 29.11. The coccyx ossifies from 4 primary centers, 1 for each segment, which appear between 1st and 20th years, and fuse with each other between 20th and 30th years. The coccyx is slightly mobile at the sacrococcygeal joint, but fuses with it late in life. Bony pelvis. The bones forming the pelvis, Latin basin, its division into the greater and lesser pelvis, and the important features of the lesser pelvis, including the inlet, outlet, and cavity, are described in Chapter 29. Some other important aspects of the pelvis are described here. Pelvimetry. The importance of the measurements of the pelvis is merely obstetric, but also forensic and anthropological. Pelvimetry can be done in the following ways. Pelvimetry on the skeletonized pelvis prepared from cadavers. Clinical pelvimetry on living subjects. Radiological pelvimetry. 1 pelvis, pelvimetry on skeletonize. The relevant diameters are summarized in Table 15.1. Pelvic measurements in obstetric cases. Pelvic measurements in obstetric cases can be done both externally and internally. External pelvimetry has been mostly given up because of its limited value. It is helpful in diagnosis of gross pelvic contraction. 1. The infraspine diameter between the outer borders of anterior superior iliac spine measures 22 to 25 centimeters. 2. The intercristal diameter, the widest distance between the outer borders of the iliac crests, measures 25-28 cm. 3. The external conjugate or body locks diameter, the distance between the tip of the spine of vertebra S5 and the upper border of the pubic symphysis, measures not less than 19 centimeters. 4. The intertuberous diameter, between the lowermost and innermost points on the two ischial tuberosities, measures 10 centimeters. 5. The anteroposterior diameter of the outlet measures about 13 centimeters. 6. The posterior sagittal diameter, from the midpoint of the intertuberous diameter to the tip of the coccyx, measures 8-9 cm. Internal pelvimetry. It is done by digital examination per vaginum. L. The diagonal conjugate is the distance between midpoint of promontory and lower border of anterior surface of pubic symphysis. Normally, it is at least 11.5 centimeters. A rough estimate of the true conjugate is obtained by deducting 1.5 to 2 centimeters from the diagonal conjugate. 2. The intereschial spinous diameter of 9 centimeters, between the tips of the spines is difficult to assess digitally. 3. In addition, a thorough palpation of the bony pelvis is done to assess the curvature of the sacrum, the mobility of the coccyx, the length of sacrospinous ligament, more than the width of two examining fingers, and the side wall for any tendency to funneling. Biological pelvimetry. It has become a highly refined technique, but radiation risks impose limitations. Ultrasound is an extremely useful and safe procedure and has replaced radiological pelvimetry to a great extent. Morphological classification of pelvis. According to anatomical and radiological data. 1. Gynecoid type, 41.4%. This is normal female pelvis, the average diameters of which have already been mentioned. The inlet is round or slightly ovoid with transverse diameter placed well forward from the sacrum. The side walls are more vertical than in the android pelvis. 2. The android type, 32.5, resembles a male pelvis. The inlet is triangular with the greatest transverse diameter placed much nearer the promontory than in the gynecoid pelvis. The subpubic angle and greater sciatic notches are narrower, so that the cavity is funnel-shaped and the outlet is reduced in all diameters. 3. The anthropoid tape, 23.5, shows resemblance to the pelvis of anthropoid apes. 4. The platypeloid type, 2.6%, is somewhat opposite to the anthropoid pelvis. Out of the various types mentioned, only a gynecoid pelvis permits a normal delivery. 1. The child. The other three represent different types of contracted pelvis. Sex differences in the pelvis. The most marked of these differences are due to adaptation of female pelvis for childbearing. Males have stronger muscles, thicker bones and prominent bony markings. As compared to a male pelvis, a female pelvis shows the following differences. 1. The false pelvis is deep in male and shallow in gemelle. 2. Pelvic inlet is heart-shaped in mule due to jutting forwards of sacral promontory. In female it is T-transversely oval. 3. Pelvic cavity is sellar and deeper in me, Fig 15.14a inset. In female the pelvic cavity Y is roomier and shallower, Fig 15.14b inset, i.e. distance between inlet and outlet is shorter. 4. The pelvic outlet is smaller with ischial tuberosities turned inside in male. In female the pelvic outlet is bigger with everted ischial tuberosities. 5. Sacrum is longer and narrow in male while it is shorter and wider in female. 6. Subpubic angle is narrower, i.e. 50°-60° in male. The angle is wider, i.e. 80°-85° in female. This is the most important difference, Figs 15.14a and b. 7. The greater sciatic notch is wider in females, 75 degrees, than in males, 50 degrees. 8. The acetabulum is large in males, and its diameter is approximately equal to the distance from its anterior margin to the pubic symphysis. 9. The chelatic line extends from the iliopubic eminence to the iliac crest. In females, the pelvic part of the chelatic line is longer than the sacral part. 10. The pre-auricular sulcus is more marked in females. Anterior surface of pubic symphysis. Normally, it is at least 11.5 centimeters. A rough estimate of the true conjugate is obtained by deducting 1.5 to 2 centimeters from the diagonal conjugate. 4. The intereschial spinous diameter of 9 centimeters, between the tips of the spines, is difficult to assess digitally. 5. In addition, a thorough palpation of the bony pelvis is done to assess the curvature of the sacrum, the mobility of the coccyx, the length of sacrospinous ligament, more than the width of 2 examining fingers, and the side wall for any tendency to funneling. Radiological pelvimetry. It has become a highly refined technique, but radiation risks impose limitations. Ultrasound is an extremely useful and safe procedure and has replaced radiological pelvimetry to a great extent. Anatomical position of the pelvis. When examining an isolated pelvis, students generally do not orientate it as it is in the intact body. It can be correctly orientated keeping the following in mind. In the anatomical position, i.e. with the person standing upright, L. The anterior superior iliac spines and the pubic symphysis lie in the same vertical plane. A pelvis can be correctly oriented by placing these points against a wall. 2. The pelvic surface of the pubic symphysis faces backwards and upwards. 3. The plane of the pelvic inlet faces forwards and upwards at an angle of 50 degrees to 60 degrees with the horizontal. 4. The plane of the pelvic outlet makes an angle of 15 degrees with the horizontal, see Fig 29.6. 5. The upper end of the sacral canal is directed almost directly upwards. Intervertebral joints. These joints include: 1. The joints between vertebral bodies. 2. The joints between vertebral arches. The joints between vertebral bodies are secondary cartilaginous joints held by the intervertebral discs and 2 accessory ligaments, the anterior and posterior longitudinal ligaments. Intervertebral disc is described below. Joints of the vertebral arches are formed by the articular processes of the adjacent vertebrae. These are plain synovial joints, permitting gliding movements. The accessory ligaments include: A. Ligamenta flava. B. Supraspinous. C. Interspinous and intertransverse ligaments. Considerable amount of flexion and lateral flexion, and least of rotation. Intervertebral disc. It is a fibrocartilaginous disc which binds the 2 adjacent vertebral bodies from axis or second cervical vertebra to sacrum. Morphologically, it is a segmental structure as opposed to the vertebral body which is intersegmental, Figs 15.15a to c. The shape. Its shape corresponds to that of the vertebral bodies between which it is placed. Thickness. It varies in different regions of the column and in different parts of the same disc. In cervical and lumbar regions, the discs are thicker in jowl than behind, while in the thoracic region they are of vertiform thickness. The discs are thinnest in the upper thoracic and thickest in the lumbar region. The discs contribute about 1/5 of the length of vertebral column. Such contribution is greater in cervical and lumbar regions than in thoracic region. Structure. Each disc is made up of the following 3 parties. 1. Nucleus pulposus is the central part of the disc which is soft and gelatinous at birth. Its water content is 90% in newborn and 70% in old age. It is kept under tension and acts as a hydraulic shock absorber. It represents the remains of the notochord, and contains a few multinucleated notochordal cells during the first decade of life, after which there is a gradual replacement of the mucoid material by fibrocartilage, derived mainly from the cells of annulus fibrosus and partly from the cartilaginous.